cold drinks? No. Let me get my computer because I want to go back to that slideshow. You didn't see it on Facebook. Me and Christy got our very first thing of mail today.
I saw that. That was sweet.
People really don't think we're lesbians.
If you're like me, is it the worst thing that can be said?
No. I'm sure much worse has been said about me. And I know it has about Jan.
What did you say?
I'm sure there's, it's not the worst that's been said about me. I said, I know it's not the worst. I'm just playing.
No, it's all real. Alright, let me go to the slideshow.
Where's your friend at? Your sidekick. She is end of the month billing. They're closing out and everything, so she won't be here Monday yet.
I sent some jobs out. I just want y'all to kind of get an idea of what's going on and what they're looking for. I think those jobs right there are that coding gig, about $20-22 an hour. But you have to watch for the part-time and the contract status because you won't get any benefits on that. But, if you're making considerably less than that, it may not be a bad idea for you to supply your own benefits.
You better take me on. I have to have a job with benefits.
It's ridiculous to have me to my husband's.
We added me and the kids to Blake, and we paid almost $700 a month.
Great day.
Yeah.
Well,
My ears is awesome.
Starting May 1st.
Once they turn 5, though, it'll go down a little bit, won't it?
2.
Not with,
2, it goes in half.
because
Well, if
Jay's
it's independent,
is,
it does.
most places have family, but his is like him, 1 child, him, 2 children,
That
him, wife.
offshore stuff is totally different and the best though. Cause
It's awesome.
when we were on John's, it was like $25 more.
When pregnant, my prenatal stuff, I mean, we paid about $2,500 total, but that's having a C-section, tubal, 12 sonograms. I think I had one just about every time I went because of my age.
You're elderly.
Yeah. And, everything they did, it was like $2,500. Oh, that was mine. Never mind, because that was mine. That was the state insurance.
When I was a kid and lived in Palms, we worked for H&P and had me on there, it was like $125 a month.
Yeah.
It's great. It really is. It was great. My leg surgery, that's one reason I was like, yes. I didn't have I did have out of pocket for the MRI. That was it. But I don't know why. There was something tooky about that MRI that they did. They don't usually do them. I guess it just didn't meet medical necessity on that level. Yeah, I know also with them, they have a lot of benefits for people who don't smoke, if you go to the gym, they actually give you money back if you keep your family healthy.
Well, see, Brooke works with the Jackson Heart. It's not exactly like that, but they have those benefits like going to the gym and stuff, because they have.
They'll pretty much pay for your membership.
Yeah, they do. They will pay, but if you don't go, if you sign up to go, they'll pay for it, but then if you don't go, you have to start paying for it.
She works for my cardiologist. I have to chat with her now.
I saw her at field day the other day, and I felt bad because I didn't need to go over there and talk to her. She's like,
I called, she's like, this is Brooke for doctors something. I was like, I know that girl's voice. And I left a message, I need to make an appointment, and then she called me back, and I was like, who is this? She's like, this is Brooke Jones. I thought, oh my God, did you know her? She's like, hi, She's like, oh girl, I just realized you know. Yeah. We went back and forth.
They're blind. I love her.
She's crazy.
all right, I'm looking at these slideshows, or these PowerPoints, just to make sure that I touch base on everything. I don't go into detail about all of this, but on slide 118, so that'd be 4 and 118, or how many's on there? 30, 30, 30 something, 40 something. It's spine surgery. Like start there, just bump over real quick and just make sure.
Well, 41.
41.
Page 40, well, hey, page 40.
And we put a lot of emphasis on the fracture care and all that good stuff when we were reviewing our musculoskeletal system. That slide right there, starting on that one, and you'll see it goes into a little bit more detail about the levels based upon the part of the spine. It gives you a little bit more in-depth information on how many levels there are at each area. Your component billing for spinal surgery. This is, remember, y'all might not remember, but I said spinal surgery was fun, Cody, because it's a lot of stuff involved for one little procedure. And it will intimidate the hell out of you, but it's like this slide right here. It says that you identify the anatomical approach, anterior versus posterior. You have to identify the number of levels on the spinal column that was treated. Was anything removed? Laminectomy, discectomy, old hardware. And I'm sure it's going to be all the pages or slides down. And after you determine that, you have to determine was hardware placed and what was done. I mean, it gets in depth, but it could be a lot of fun. So it's really important to understand the spinal guidelines, again, anterior, posterior, all that good stuff. Just read over those, is all I'm saying. And then the respiratory system is a few slides over. We went through, I think, pretty much all of this. And what we didn't is in the study guide. Coding for intracardiac procedures. A few slides over. These are like the chest tube. They always enter the thorax for open procedures. Touch open. Loose negative vacuum. Loose. Allows looses. I don't know what that is, but it allows the lungs to expand. That third bullet is important. The chest tube is always required and as such not separately healed. Again, components of surgery is that they have to cut you open to get to your hernia. You don't feel the incision that's in the code. So just try to keep that in mind when you're looking at these operative reports, such stuff scenarios in your study guide, and you're seeing all of these little procedures, or they're all tied in to that particular code for the major procedure. We're not going to go into our cardiac cath procedures so much because those are in the medicine section. So I'm going to skip to vascular surgery. And that's where I showed you guys the tree, if you will, thread, appendix F or something in our book. And it showed you first order, second order, third order. That's what all of that's going over. I was interested, well, I was sent to y'all yesterday. Interesting article I got from someone at one of our sites is the AMA books published like 3 pages of revisions to those books. I'm like, you know, what are we? We're in April. You just now figuring out your books are wrong. It just gets me. And then they tell you AMA books. AMA knows what they're doing, but they're not published. Hemic and lump. If you guys didn't get a chance to go over your study guide, you really need to. We keep asking you to do that because you need to know these terms. 40000, that slide was like the 40,000 codes. With the endoscopy, you need to know where the MD started and where he or she ended up to choose the correct code. And we went in a little bit of detail about that. When they do an EGD, upper gastroscope, they can go through the trach or through the mouth or through a colostomy. So it's always important to know that those endoscopy codes, and all of them, not just the EGD codes, but any of them that do it with the scope, other than legs, of course, they're not giving it to organ, you know what I'm saying? If they're going in to inspect your inner organs, there are several different ways to get into them. So just make sure you're looking for that. On the next slide, it says location, location, location. A lot of those scopes, they are, the code descriptors are based upon how far they go with that scope. That they only go to the, a certain, I can't remember off the top of my head, but if you look at the colonoscopy codes, some of them go to the full terminal ileum, and then some of them stop at the small intestines, or, like, it's all different, so you need to make sure when you're looking at your test, you'll see that the same procedure is in the book twice, but the difference is how far the scope moves. Just keep that in mind. And then that third bullet, again, they're telling you that they can enter through a stoma to get access that organ if necessary, which again will have a different code. Multiple procedures via the scope. They're already in the gastro, and I don't think we went into that, but we will. You remember I was saying that if they say it better, the 4,000, 440,000 location, location, location. The next slide, multiple procedures via the scope. If they remove multiple lesions of the colon by distinct techniques, you can bill per technique, not per lesion. And that's a general rule to remember when you're dealing with any type of scope. They can bill for different techniques, whether it's a snare biopsy or a cold forceps or hot forceps biopsy. They cannot bill 3 scope codes for the removal of 3 lesions. Because if they put it in there, if they get 100 lesions, it's still 1 code. You could, if it was that many, you could put a modifier on it that 22 to make it a more comprehensive, more complicated, or what have you. So 22 increased procedural service, and I think there's a rule out there by Medicare that's going to be over 15 or something. I can't remember. I could be wrong. Number don't quote me, but you wouldn't multiply. You wouldn't have more units by the lesion permit. You'd only go. Let's look at our cardio in our book again, starting at 33010, page 110. And everybody's ready, guys. We'll be back in our cardio section. We're just going to do a quick one drawing before we go on. Whenever our pacemakers are implantable, our defibrillators. And your cardio conditions, the definitions thereof are all in here. And for instance, arteriosclerosis, like what the hell is that? It's a blockage, hardening of the arteries. It's important to understand what arteriosclerosis is so that you'll understand CAD, coronary artery disease, and so you'll understand CABG. Hey, I'm in class. What's up? I'm in class. You okay? It's okay. I'll cry about it. endocarditis, heart failure, pericarditis, peripheral artery disease, your PVD, peripheral vascular disease, and your PAD. That right there is where you're going to be dealing with those peripheral surgeries where you have to just determine your first order, second order branches. Your valve disorders, your myocardial infarction, better known as a heart attack, is right there. It's good for you to have a good background on that, especially when it comes to your ICD-9 code, if you understand it. Chronic MI, old MI, and then new surgery. That we're going to skip over the pacemakers and defibrillators. If y'all have any questions on it, just let me know. Your cardiac valve procedures. You got 4 valves: aortic, mitral, tricuspid, and your pulmonary valves. Shows you right there, they've got T codes, the 0256T through 0259T, to report implantation of a catheter delivered prosthetic heart valve. Those T codes, remember, those are in the back of the CPT book, and what those tell you, these are the category 3 codes. These are the new ones. And usually they don't stay in that area of the book for several years, and it's determined whether or not permanent code is needed for them in the book. Let's see. Cabbage, your CABG is cabbage. It's performed to bypass blockages, and the way you code them is determined based upon the graph, and if it's arterial, venous, and how many vessels or veins indicated. There's a lot of information there. The main thing to know with these are your modifiers, and it's the last paragraph of the cabbage area. It tells you do not use the coronary artery modifiers on cabbage. You would think that those would apply to that since they're bypassing valves, and that indicates which one it is. But those modifiers are only for your calf procedures that we talked about in the medicine section. Your angioplasty, bypass graft, central venous access. We talked about that, about the saline lock and drawing blood, all that good stuff. The last paragraph on page 141, your injection procedures. And the only injection procedures that are in here are those that do not require infusion or injection. Your infusion and injection codes are in the medicine section as well. And most of the procedures that are in the vascular injection section, 36,000, are bundled with your infusion services. The only time you would code for these is when there is not a greater procedure. And then it goes further on into that vascular family order on page 142. And I'm not being able to say this, but one reason I go through all this is because I know y'all can go home and review it. So that right there, vascular family order, y'all review it. You're gonna have to understand that. They'll have maybe one good big make you mad question on the test with those vascular orders. Because usually even the most skilled coders have difficulty in that area. A lot of people who get that don't get the rest of it. I guess you gotta, or whatever, Kathy said she was good, I should have to. Endovascular revascularization, radiology, goes into a little bit more information about that. Just as any of the other codes through the book for your procedures, and that's one good thing about these books is your little radiology symbol in there indicating that there's a radiology component to that is not included, and it just goes over that for you. Cardiography, we're going to skip that, and then we're going to go to adjustment. I don't want to go into the medicine section and just not hit it as much, although this book is actually better written to include your ICD-9 portion for each chapter and the codes that are in the medicine or radiology section that would apply to that chapter. Your digestive system starts on with your study guide, and we're going to skip all the way over to, because that's all about diagnosis and conditions, all the way to 158.
Sorry.
When you're thumbing through your cardio section, you'll see that there aren't any, they've got a lot of notes, section notes. I think we've covered them all. There aren't any. There's a lot of code also. You're going to see code also. And again, that doesn't tell you to lose the primary code. It means in addition to, so you have to, in most cases with cardiology, 3 and 4 procedure codes. Just pay attention to the section notes you need. Digestive system. You start with your lips. Those are pretty straightforward. One thing to remember, and it's here in the study guide, is that remember whenever a biopsy code for our skin, the lip isn't considered skin necessarily. If they do the, how do they put it? And they should show you not just a wedge biopsy. Go to 111. Let me go to this biopsy because I can quote it from you. I have that backwards. Read that, that's important. I would have gotten that wrong. If a procedure is performed on the skin of the lips, do not code from this section. You would choose one from the integumentary system. Biopsy of the lip is performed on any portion of the lip. 4049 knows what we're talking about now. A biopsy would be performed when there is concern for malignancy. So if you look at 40490, it does, right above it, it tells you excludes procedures on the skin of the lip. So they do differentiate, I guess, the outer layers versus the inside portion of the lip. Incision and resection of buccal cavity, those are straightforward. Repair of buccal cavity, floor of mouth or tongue. Resection or repair of tongue. What's great about the digestive system is the way that it's formatted in the book, it's like it works its way down. So the first part of the chapter is at the top level, and you just go through, you'll see salivary ducts, your esophagus, your upper GI endoscopic. Procedure start on 43200, and that's really what we're going to talk about more than anything for the digestive system. On page 160 of your study guide, at the intestines, stomach, surgical, intestines. The second paragraph, endoscopic procedures are divided by the small intestines beyond the second portion of the denum and stomal endoscopy. And that's, again, not only how did they approach the intestines or the mouth, the stoma or rectum, but what level they went to. And when you look at these codes, these endoscopy codes, you'll see you've got pages of codes that are all the same procedure, just doing different things 43200 is esophagoscopy. And if you just read that descriptor, rigid or flexible diagnostic with or without collection of specimen by brushing or washing. And all of the codes after that are the same except with directed injections or with biopsy, with something, you see what I'm saying? They're all the same except they all are for different smaller procedures to the greater one. If you had an esophagoscopy and they did a biopsy and an injection, you would code both 43201 and 43202. If you had a esophagoscopy and they biopsied 2 lesions, however, you only code 43202. Again, you code based upon technique, not number of lesions. And that's going to be the general rule as you go on into the rest of your endoscopy codes. From your esophagoscopy, you'll see that you've got upper GI, 43235, EGD start here. Same format, except the 43235 are entering through the mouth, all the way through to 43224. This one where they enter through removal of foreign body, insertion of gallbladder, balloon dilation, removal of tumors, removal of total bleed, transesophageal stent. Ablation tumor. Yeah, the further on the back, it goes 43644 though. You know this one? It's on 44380. From page 156 is where we were with the EGDs, all the way to page 166. These are all full of, well, no, they're not, but there's a lot of them are EGDs, and what happened is they run out of room and they brought the colonoscopy or stoma, entering through a stoma code without referral. So you'll see, for instance, 44388, colonoscopy via stoma, and then upper GI 432. Insertion of blood work, control of bleeding, and throughout the intestines, those are usually the general selection or options is, this, the foreign body removal, they'll have, specific codes for each of those types of procedures associated with that scope. Endoscopic procedures, ERCP 4360 through 43273. These are your retrograde, and I can't ever say that, the ERCP. Basically, they're going in and they're ultrasound of your gallbladder, pancreas, all that good stuff. And then you've got all of your procedures listed under there in association with it. Another thing to remember is when you're looking at your up report, a lot of times we focus in on these new endoscopy codes because there are so many more codes for scopes now than there are the actual open procedures, and a lot of times you'll forget the fact that when they didn't remove that hernia via laparoscopy, they actually opened them up. So you may code the right procedure for the scope, not an open procedure. So keep that in mind when you're looking for it. Procedures of the esophagus is the same, 43279, your laparoscopic procedures. Then you get into your open. So you see they got different sections for scopes versus opens. You got dilation, esophageal dilation, and then your unlisted codes or other codes. And every section has an other or unlisted code section. These aren't to be utilized very often. They're the ones that you just cannot code with anything else. But they don't ever get paid, and or they're usually some that are cosmetic or require additional information from the insurance company. Your test should not have anything on that word. You're looking at unlisted code for anything. Your open gastric incisional and resection procedures 43500. Remember when you're looking for biopsy of the stomach, you might think, oh, I've got it right here. Just always remember you got open versus scope. Those are pretty straightforward. There aren't any real big rules in regards to any of these codes, other than the scopes. If you look at the bariatric procedures right there on page 161, page 1 to the next page, even those, as complex as they are, they're pretty straightforward. They don't have any section notes for them. Your incisional and resection procedures of bowel, page 163. Always keep in mind that if they're, not all the time, but most of the time, if they are removing intestine, they're usually leaving an opening, an opening to the outside, whether it's colon, how do you say it, colostomy, or ileostomy. There are several different areas that they can go from with a tube to feed the outside. But most of these, they do an anastomosis where they hook them together, and there's another code for that. It's 44, it's an add-on code. And it's a huge troublemaker code. 44139. You'll see that 44139 colon resection procedures is how that section reads. And it's all the time missed or not coded appropriately. You see your plus sign right next to it. It's an add-on code. If you don't know that that code exists, you would think that it's included in the greater procedure, but it's not. 44139 is the mobilization, the takedown of the splenic flexure performed in conjunction with a partial colectomy. Partial colectomy was a colectomy. Take out of colon, intestines, ectomy, removal. And this right here is them getting ready to whether or not they're going to do a stoma or an anastomosis, you still have to do the takedown. And I'm sure they go into a lot more detail about that in the discussion. Interesting. No, they didn't. laparoscopic enterostomy procedures. The main thing to remember about all of these codes is that decompression, surgical jejunoscopy. If you look at 44186, 44202, well, no, 44186 is surgical laparoscopy for decompression or feeding. This is making a stoma jejunostomy. You don't, I don't know how to say this, but, 44186 is them creating a stoma from the jejunum. It's a part of your intestines. It tells you there for the decompression or feeding. The one under it, the ileostomy or jejunostomy, non-tube. It's for different, those are, if they've got a tube, it's for feeding. Or the decompression. The 44188, surgical colostomy or skin level cesostomy. And then if you keep on going down, you'll see all of these are all codes that are performed laparoscopically for stomas. Now, 44202 actually bundles the resection and the anastomosis. And then 44203, each additional small intestine resection and anastomosis. Colectomy partial with anastomosis. Colectomy partial with removal of terminal ileum with ileocolostomy. It's a lot of information. 44207, in parentheses, low pelvic anastomosis. That means something totally different. When you see your opera report, just be conscientious to what codes are out there and know what your options are when you're reading this information. And sometimes it's just, that light bulb, oh, there, I saw a code like that. All of these colectomies, the removal of the intestine, the operative report will tell you whether it was a partial or total. That's not something that you've got to calculate. It'll tell you. And they'll also tell you whether or not they had a stoma placed for anastomosis and whether or not it was any type of takedown. They'll tell you. I guess the main thing is what I'm getting at, I'm going to go on and on that is every word is going to make or break this code. It's like the fractures. My most fearful thing is that you not understanding the procedures itself and not knowing what they're doing, that you don't know what words to look for. So that's why it's very important to get that terminology under the belt. You've got one add-on code here, 44213. Remember I pointed out that other add-on code? The difference in those is one's laparoscopic and one's open. Then you've got your open enterostomy procedures. Next page, your endoscopies, again, of the small intestine. And you'll see the difference in 44360 and 44376 is that 44360 does not include the ileum. It's enteroscopy beyond second portion of duodenum, not including your ileum, whereas 44376 is series after it, same format, they just got different with removal or with biopsy or with ablation. But the difference in those two little sections under the endoscopy area is that one of them is beyond and one is not. 44388 or 44397 colonoscopy via a stoma. And then 44500 gastrointestinal intubation. Open repair procedures of intestines, other intestinal procedures, backbench transplant procedures. That goes diverticulum and dissection procedures. There, you'll see that there's not any section notes, they come as they are read. Open and transrectal procedures of rectum. In your appendix, those are good. Remember though, 44900 and 44979, the most important thing with your appendectomies is to know whether or not it was laparoscopically performed or open. It's huge difference. Just remember that with all of your surgical procedures nowadays, because there's usually that option. Your plectosigmoidoscopy, rigid and flexible. That's a difference in page 169, those sections. And the note will tell you whether it was a flexible or rigid. But you'll notice that colonoscopy doesn't matter. It's flexible and rigid. If the code is the same, it doesn't matter. 45395 through 45499, your laparoscopic procedures on the rectum, and then it goes to your open procedures on the rectum. Those are pretty straightforward. Closed procedures of rectum with anesthesia. Reduction of, what is that, procedentia? I don't even know. Dilation of anal sphincter, dilation of rectal stricture, removal of fecal impaction of foreign body under anesthesia. That's the key word there. Most of these are under anesthesia, but if you look at like 459, let's see. Yeah, all of these are, but other than local. So when we were going over our anesthesia, remember we had our MAC, our moderate, and then our locals, and then general IV, and all of these are under anesthesia. If they perform, for instance, a fecal impaction that is not under anesthesia, those are generally done in the office, and it's included in that office visit. You can up it a level from a 90212 to a 90214 based upon the time spent with that. 45990. These, and you'll see under it, there's a little bit of information, and that's because there's a lot of error made there. These are the anorectal exams. Again, being that it's in this section, this is the surgical code here, and these are diagnostic only. It's not when they're performing a procedure, it's when they're just looking. They're trying to figure out what's going on, they're not doing anything. You'll see under it, it includes an anoscopy, a proctoscopy, the exam of pelvis, perineal, external, rectal, digital. 45900 is requiring anesthesia. Where is the one that is not? Anesthesia. 46600. Yeah. 46600, you'll see. Is anoscopy diagnostic with or without collection of specimens by brushing or washing. You'll see it doesn't say anything about anesthesia. With or without anesthesia. That is where you go with that. But the 45900 is when it does. There aren't very many codes in the book other than this one and I believe cerumen impaction, which is impacted earwax, and something else where the codes change based upon whether or not anesthesia is included. Because remember, the global package, most of these are major procedures with a 90-day global, and all of that is included in that. And you don't separate local anesthesia from it. But there's a big difference in those procedures when they require anesthesia, and that's why they're different codes so that doctors are getting paid for the amount of time they spend doing it. Alright, back to 45990. 46020 through 83, surgical incision of the anus, those are straightforward. But what gets me every time are the hemorrhoid procedures. don't know now. You'll see that 46200 resections and hemorrhoidectomies. They all are different based upon whether, number one, they are internal or external hemorrhoids. The columns or groups, these are new. Well, revisions, not new codes, but revisions terminology. The numbers have changed. They've tried to put them in order a little bit more. They're everywhere. You'll see when we go that they're just kind of everywhere. But anyway, you've got your fissurectomy, hemorrhoidectomy, internal by rubber band ligation, hemorrhoidectomy, internal by ligation, other than a rubber band, single hemorrhoid column or group, and then two or more, excision of single external papilla or tag of anus, and remember when we were talking about removal of skin tags? It's the same thing with the rectum. If you've got rectal tags, it's not considered a lesion so much. They have their own codes. Excision of both hemorrhoids, external, and then hemorrhoidectomy external, two or more columns or groups. And I think the reason why I always have a hard time with these is because I can't understand what's the difference in a hemorrhoidectomy and an excision of a hemorrhoid. It's the same thing. I need to read up on that. Hemorrhoidectomy 46255, internal and external. Fissurectomy is under a fistulectomy, including fissurectomy when performed. There's a lot to think about there. Remember, for instance, 46946, two or more hemorrhoid columns or groups. So if I had 4 that were ligated, I would only code 46946 one time. It's not an add-on code, it's a standalone code. And it doesn't say each. Remember when we went through that terminology? I don't know if I was here to work with it, because that each and separately, it made a difference, and that is not like that, so it doesn't matter. It's 2 or more, 46946 or more. 46500, other hemorrhoid procedures. I think this is where they took the old codes and moved them over. 46600 through 15, your endoscopy codes. These are your procedures. Anal repairs and stable hemorrhoid pexy starts at 46700. And then 46900, destruction procedures of the anus. One thing to always remember, you remember when we were doing our destruction codes in the skin section, it's the neural 171. Destruction of benign lesions other than skin tags or cutaneous vascular proliferative lesions. If it was like a wart, you would code it to 17110. However, some body parts have their own codes for the same procedure, destruction of lesions. The anus is one of them. 46900. It tells you that the destruction of the lesions, whether it's condyloma, papilloma, molluscum, herpetic vesicle, and then they have different codes based upon the type of destruction, whereas in the skin section, that destruction code for the skin lesions was any method. They didn't say, 171111 for electrodesiccation. It was all one code for whatever technique they used. When you're unsure if there's a more specific code for destructions of lesions, it'll show you, go to the skin section, and it'll show you right above the section notes that it excludes the destruction of lesions in those body parts, and anus, conjunctiva, eyelid, penis, vagina, vesicle, vulva. And I mean, think about it, the reason why is because those require more effort and take a longer time, and in their own right will deserve more reimbursement for the physicians. 46930, destruction of internal hemorrhoid by thermal energy. I told y'all they're everywhere. Every time I turn around, I see a hemorrhoid code in this section, and I hate it because I want them all to be together, and I hate it. But anyhow, needle biopsy of liver, open incisional and resection procedures of liver, liver transplant procedures, open repair of liver, laparoscopic ablation of liver tumors, and you can read on into page 79. Every organ in your abdomen or digestive system is the same thing. You've got the open, endoscopic, open, endoscopic. 49203 through 49205 are for destruction of excision of abdominal tumors. There's a difference in a small lesion and a tumor. It's good to know that those codes exist. Because you don't see the term tumor used very much in the CBT book except for this section, and I think neurology with the brain. Because remember when we were talking about our diagnosis codes and determining what correct diagnosis you go with, a tumor is a ill-defined term. It doesn't say if it's malignant or benign. But what a tumor does demonstrate is a complexity of a lesion before a provider will designate it a tumor. And that's why they have it on codes. The only other thing in this section is your hernias. Really. Now, if you, like on page 181, you'll see that, these are your odd and ends and stuff at the end of every chapter, and it's funny. You'll see 49320 laparoscopic procedures of the abdomen, peritoneum, omentum. That's all of your internal tissues that aren't necessarily organs. And then you get your peritoneal procedures, and then over here, your insertion of a percutaneous gastrointestinal tube. What do we call those? PEGs, PEG. They're over here. Your percutaneous conversion of a gastrostomy to a gastroduodenostomy tube. You've got your, anything that deals with a tube, you've got a few series of codes there where you would think that they'd actually be in that body system or what have you, so don't forget about those tube codes. Your hernias, there's a big thing about hernias. What's important to know is number one, what kind of hernia it is. There's several different kinds. You've got umbilical, you've got inguinal, you've got ventrals, you've got incisionals, your femoral, ventral valve, yeah. So number one, you have to know what type of hernia it was. Then you need to determine whether it was an open procedure or a laparoscopic procedure. Then you'll see all of these codes, or most of them, not all of them. They are determined based upon two factors: age and whether or not they are recurrent hernias. Because the scar tissue requires more time in the OR and more physician's attention, and that's when they have separate codes. And it shows you there's one add-on code for your hernia codes, and it is 49568. 49568, however, only applies to certain hernia repairs. And I believe it's ventral and incisional, that section. That mesh, implantation of mesh, you'll see that they implant mesh for all of these hernias. However, the only one you can get paid and report it for is incisional and ventral. That, just make a little mental note that that code is only, and it tells you their code first and what codes it applies to. If the code you're trying to add this to isn't there, then it isn't applicable. You can't bend the rules. that's basically it on your digestive system. Urinary, we'll go to our study guide and do some scenarios after we get through some of these chapters. Urinary, remember your kidneys are there. I don't know why some people forget. Because it's not your bladder or whatever, it's not your urine system, but that's how it all comes together. So you can see your bladder and everything. So there's your kidneys. They're pretty straightforward. There's nothing, we can't think of a single thing about these that's ever given me a problem. The only thing that will throw a red flag up for anyone is when you get into your laparoscopic cystoscopies, which is into your cystoscopy. Cystectomy. 51501. Injection procedure. There's a lot of things that are out there that most of us don't know about until you start reading this, and it's like, what the hell is that? And it's 52,000. 52,000, you'll see it's got in parentheses separate procedure, and it's been my experience that any code in this book that has that next to it, the section it goes with, has given people hell, and that's why they had to put separate procedure there to indicate that this is separate. They shouldn't have to, but there's a long history and also a lot of confusion with those sections. Cystourethroskopy. All these are kind of like the GI colonoscopy, upper GI scope codes. Other than that, there's a lot more involved because the passages are a lot smaller. So just like 52235, for instance, the tumors, the code series is based upon the size of the tumor rather than anything else like it was in GI, because what the space they have to work with is so much smaller. The only time you have to worry about size and stuff, I think, in your GI codes for your endoscopes is when they're doing dilations, because different dilations, opening of passageways require different scopes, whether it's a balloon pumping it up to make it bigger, or actual dilation where they zap it. And I can't think of anything else where you need measurements for things. What else with this section? Don't forget when you start getting your urinary system, especially your male and female, because they may have different codes for the female genitalia versus the male, even though it's still a urinary system, because their methods of getting there is different. 42285, for instance, there's one that's a gender-based code. You'll see your male and female signs indicate that for you. They should have those indications in the A tables too. If not, just make sure you read it carefully to know whether or not it's female or male. Don't just assume, just reading it, glancing at it, and thinking that's the right code. Right now, you guys have time to read your code descriptors, but you're going to see when you're under a time crunch, and when you're even working with your job, you don't sit there and read every word every time. You start thinking everything's applicable to everyone or what have you, and only until you mess up a few times do you realize, okay, maybe I need to stop and do that. So I'm just trying to figure out things to think about. 52332. These are your insertions and stamps. You've got several different types of stricture procedures of releasing stricture, whether it's putting a stent in or electric artery, balloon dilation, laser. Whether a guide wire was used or not is going to make a difference. When you get over to 52400, you see these are procedures via the urethra, prostate, and vesicle neck. This is all for your men here. See, if you're looking for those actual codes for a female, it would have taken you somewhere else. One thing that's yeah, it is, your urodynamics. You'll see it on page 178 of your study guide, but in here, 1725, these are, 1725, your urofluometric evaluations. I guess what gets me about these codes is that for any other section of our book, our surgical section, any type of invasive procedures like this that are performed in the office setting, you'll find back here in the medicine section of the book. So these get overlooked and forgotten about because everyone thinks they're supposed to be back here. They aren't major procedures or minor procedures. It's kind of like your skin, a lot of your skin codes, or 20610, for instance, where your joint injections are all, most of them, unless they're under anesthesia, are in the office setting. So most office setting procedures are back here in your medicine section. Just remember that these are here. These include your voiding pressure studies are a big thing. What they do is they'll pump you full of fluid, and then they'll get ultrasound, and they'll watch you either the fluid move through you as you let go of it sometimes, or the pressure behind your flow. Some people get split streams, or what else? I'm trying to think. There's all kinds of PPN issues that we don't think about. And this is their way of measuring the post-void residual, whether or not you're retaining urine. If you're having hesitancy when you TT, this will tell them why, whether there's a stricture or a tumor or something. But all of these are performed in the office or office setting. They're not an OR-based procedure. You'll see all of the level for 0R, XXX, and considered minor procedures. You'll also see that EMG 51784. When we get into the medicine section, y'all are all be like, yeah, why did they do that? Because all of your EEG and EMG codes are in the medicine section. I really think that they should have moved this a long time ago. I don't know why they didn't. 51800, open urinary system repairs. Then 51900, laparoscopic. 52,000. These are those cysto codes that I don't like. Again, you see your separate procedures via urethra for the renal pelvis and ureter. We went through all these, and then your prostate, vesicle, neck, that's your men. All right, then your open procedures of the urethra. Remember we talked about endoscopy codes. These are your open, and then urethral dilation. Those right there are male and female based codes. Endoscopy procedures via the urethra to get to the prostate. These are relatively new, and that's why they're back there. Alright, then you get into your male genitalia. All of these are pretty straightforward. The main thing here to remember is your circumcision procedures, 54150. It tells you code also modifier 52 when performed without a dorsal penile or wrinkle up. That's the main thing to remember with that. It's right there in front of you though. Again, I've been talking about this anesthesia and stuff. Most all procedures, they bundle it in. If they don't do the typical anesthesia, you don't worry about it unless it tells you. And when it comes to circumcisions, it matters. Another one is your prostate. your prosthetics, your penile prosthesis. You've got well, they're not new anymore. They were a few years back. But 52, modifier 52 is indicated in several of these, just like it was with your circumcision, based upon the services performed, because all of those require the whole shebang, or bundled into that code. Testicular procedures, incisional, those are straightforward. Open and laparoscopic testicular procedures, and then procedures of the epididymis and human children. Your vaginalis and scrotum, and then other male genital ducts and glands, all straightforward. Nothing too key about those at all. Your prostate incisional, those are good. You've got your biopsies, however, on page 205, code series 55700. And if you look at your study guide on page 179, they are identifying the difference in the terms incision, excision, repair. And it's very important to understand that terminology, and that all three of those are three different things in order to get the right code when it comes to your prostate. Whether they incise something, cutting it apart, excise it is taking it away, or repair it is fixing it. So, again, you got your open prostatectomy, your laparoscopic prostatectomy. Then you got your transsexual surgery. So, then you get into your vagina, straightforward. There's nothing about that other than just like the lips and we didn't go over to the male genitalia, but the female genitalia, destruction of lesions, condyloma, just like the anus, you've got different code sets for the destruction of skin lesions. And I'm not real sure, like 56501 is destruction of vulvar lesions. It doesn't tell you there, to see whatever for different sites or whatever. But if you're ever unsure, when it's dealing with destruction of lesions of your outer body, always refer to your skin lesion destruction codes, because it specifically tells you which body areas have their own types of destruction codes. These are all pretty good. There's one thing about the external female genitalia that comes to mind, and that is that they have a particular code for Bartholomew's cyst or something like that. What's it called? Yeah, that's it.
It's 206. Got a little dot picture there and everything.
Right there. You'll see that it has its own particular code there for the marsupialization of the Bartholin's gland cyst. But above it, it said excludes the incision and drainage of subcutaneous abscesses, and it tells you where to go with those. That's one cyst where it has their own code. A vulvectomy procedures, repair, reconstruction, external female genitalia, vulvar colposcopy with and without biopsy. These always get missed. And I'm going to show you one. When you go in and have a leak performed, 9 times out of 10, they do a biopsy of the vulva. And because it's so common that they perform that biopsy while they're doing a leak, those codes think that it's included, and it's not. That can be coded separate from the leak. It does tell you colposcopy procedures and or examinations that are excluded are there. Those that are through the cervix and the vagina, 57420, and those are, which ones are, the ones that I was talking about are the 57450. Dilation, courage, dilation, and radiation. Look at 57410, I think that's it for this section. I just started this up, but your 57410, you got a pelvic exam under anesthesia. It's important to know that exists. For various reasons they can do that. A lot of times they do that for mental retarded people, or for people who are exhibit a lot of pain, or when they know or have a good feeling that they're going to find something, and they just want to go ahead and get it done. Like Lawrence's mama, they knew, based upon the test results, that something wasn't going on, so they went ahead, put her under, did the exam in, and then went ahead and cut her open. So, you got your dilation of vagina under anesthesia here as well. Removal of impacted vagina, foreign body, under anesthesia is here. If these procedures, all three of these are performed without general anesthesia, other than local, they are included in the evaluation and management code. They're not separate procedures. So then we're going to go to our hysterectomy codes on page 211. Remember with your hysterectomies that you can have partial or total, that you can have your uterus removed, not your ovaries. There's different variables, remember that. So when you're looking at your codes, your cervix, your cervix, or your uterus, so, but they tell you remove all the tubes. Is it both?
Wow.
Well, yeah, because your uterus is in your cervix.
It's all one.
Duh, yeah. We're like, yeah, our uterus and our cervix. So yeah, and then you got your tubes, your ovaries, all of that. It all changes, and the uterus, the weight is it changes the codes too because it requires more effort to get it out if it's larger. Now you'll see you've got contraceptive and reproductive procedures you're going to be trying, and reflecting off of what I said about most of these that are performed in the office, you think they're the medicine section. In vitro, of course, is one that is considered not high risk, but it's highly complex. That's why it's here. Your fallopian tube patency and brachytherapy procedures, ablation of endometrium, uterine repairs, vaginal and abdominal, laparoscopic procedures on the uterus, other uterine endoscopy, sterilization by tubal interruption, clips, endoscopy procedures to the fallopian tubes and ovaries, and then you've got your open procedures for ovary, removal of ovaries with or without multiple procedures for malignancy. That's a totally different section for that. The reason why is usually if it involves the ovaries, it involves the outer structures, whether it's your omentum or peritoneal cavity itself, or the connecting structures. And that's why they've got all these different types of codes for your, you'll see 58956, oophorectomy, and hysterectomy. We have the hysterectomy codes back here, but these are for malignancy. In vitro fertilization, aspiration of amniotic fluid, and this right here, diagnostic. 8970 is, we're starting pretty much, maternity care, they didn't give us a setting. So we're going to that. Make sure that we're good anymore. Maternity care is kind of quirky. So glad we got all about that. Maternity care is normally packaged. So for the bundle service, your prenatal, you're having your baby, and your postpartum. What happens is if you change a doctor, or you move, or your doctor dies, or whatever, that global surgical package is split up, and everybody's trying to get paid for something that one person normally does. So you're going to find that with your delivery codes and some of the other codes, that they are specific to the level of care that that provider is giving the patient, whether it's prenatal, delivery, or postpartum. And it talks about that more, page 194 in your study guide. The only big thing about, look at page 218 in your CPT book. You'll see it starts off prenatal and postpartum visits. Then you've got cesarean section delivery, comprehensive key components of care. And then you've got your vaginal delivery. After prior cesarean section, comprehensive key components of care. Cesarean section after attempted vaginal birth, prior C-section, and then you skipped on page 270, 217 is where it all started. It's your vaginal delivery, comprehensive key component services. So they're all one and the same. They're all having a baby. The approach is going to be vaginal versus cesarean, and the variable is going to be whether or not they've had a previous cesarean or attempted cesarean. Then in each one of these sections, the components are the prenatal routine OB, your postpartum, or whether or not she's delivering. You guys see that? They added 59525 a few years ago to the cesarean section code, and you'll see it. 59525 subtotal or total hysterectomy after cesarean delivery. The reason why they have a different code is because they have to do all the work there and split you open and get your baby out. It's just good to know that those are the variables and not being good looking.
That's why they won't give you hysterectomy after C-section.
Already in there messing with everything.
That's what I said. They would, he told me it's a different code.
Who they paid?
That's really.
Trying to look at this one. I'm not gonna pay much attention to the excludes and includes in here, because I don't wanna confuse y'all way too much, but it does tell you what these routine OB care packages include. And complicated visits outside of routine OB care is not included. Jean saying that she had to have all of this testing 38, Olivia. So she was required to do all these tests and everything. They're not included in a routine OB package. So that's why it was over and beyond. After that, you're in the abortion codes. And then miscellaneous obstetrical procedures. So we got make sure you guys are reading the study guide, they really go into detail about all of this. Before we get an endocrine nervous system, you can go to endocrine. Endocrine's one page. Here's the sign. Those are straightforward. Look at that. And you'll see on your state guide, endocrine guide for a page. You got an endo page. And then you start talking about the nervous system. Thyroid is all here, pretty straightforward. Nervous system. This is your brain, your nerves, your nerve blocks, your pain management. The main thing for me in this section is the actual pain management approach. And we'll talk a little bit about that, but on page 223, you see your transcranial access via puncture, burr, hole, twist hole, or trapectomy. Craniectomy, craniotomy by indication specific area of the brain nodes. And these are complex and very intimidating procedures, but the procedure itself, there's no room for look over it. Craniectomy, decompression brain by surgical approach, specific area of the brain. Procedures, implanted electrodes, carotid, choroid, plexus, craniopharyngioma, or whatever. They're all there, lobectomies. Removal pituitary gland or tumor. Craniosynostosis, whatever that is. Removal of cranial bone tumor with or without optic nerve decompression. Craniotomy procedures. Removal of foreign body from the brain. Transoral approach to posterior cranial fossa, upper cervical cord. Cervical approach for the cranial fossa. All of these are, if you see, there's no section notes. I haven't seen much error made in this area. definitive procedures for the craniofossa reconstruction, post-surgical craniofossa defects, neurovascular interventional procedures. We're gonna step all the way over to we'll get on page 231. One thing I just wanna make you guys think about, code 62220. With these shunts, and you'll see it's throughout this area, they not only do they have codes for the placement of the shunt, but whether or not it's a revision, whether or not it was reprogrammed, all of those different variables. Just know that those are the things you're dealing with when you're looking for that code. Like 62256 is the removal of the complete system with or without placement. Without placement. License of epidural lesions with injection. Blood catheters, epidural injections, epidural catheter placement. On 234, you'll see procedures related to the epidural and intrathecal catheters. It's important to know that those exist. And these could be on a pump as well. That's a different variable. You'll see the new codes with the bullet and then your triangle for revision for those. Your laminectomy codes are there. Laminotomy. You'll see that these are based upon each additional interspace, kind of like our spinal. It's pretty, I don't know, I understand they're two different things, the nerves and the bone, actual removal of a spinal column, but the laminectomy is one that they're kind of reflect each other in the format thereof. So you've got your decompressions, your they're all, whether it's thoracic, lumbar, cervical, and the levels. The approaches are the same. Remember, anterior, posterior. So you have to think about that, and you see as you're going through, coming through, that they got anterior, lateral versus posterior. You guys all the way to your vertical pulpectomy for intraspinal lesions. Stereotype procedures of the spine, spinal neurostimulation, repair of congenital neural tube defects. With the spinal neurostimulation, there's a lot of things to think about with that as well. It's not just the electrode, but the paddles, I think it is. Yeah, electrode array, epidural, plate or paddle epidural. That's the difference in 63650 and 63655. And you wouldn't, not knowing what it is or understanding the procedure, you might not know that there are paddles and plates versus electrodes. And then these, I think all of them. The removal codes include, and the revision codes include fluoroscopy or the radiology portion, whereas 63650 and 63655 Revision including replacement, insertion of replacement spinal repair, cerebrospinal fluid, your shunt, your lumbar shunt, 63740 through 46, and then your cerebrospinal shunts, 63707 through 10. Those are there. Your nerve blocks, you'll see that your nerve blocks are coded based upon the nerve that was injected. Sometimes they won't show you that specific nerve. They're talking about, like in your operating report. I can't read the speech. Your procedure report. In your procedure report, they might have a baby branch from the main branch. So if you don't know, if you can't find, if you can't find the branch you're looking for, go to that back of your book and look to see which one you go to. Because not only do they have vascular families, they've got your neuro families back there. Transforaminal injections. There's a difference in a spinal injection and a transforaminal, and I'm not real familiar with all this, I'm gonna get it wrong, but basically you've got your spinal column and your bones, and I think they've got something here, and then you've got like an outer layer around your bone, like cartilage, and then all of these nerves are around there. You've got the transforaminal is, that's the approach where they go into here it is. Page 210 in your study guide. Instead of the two, which means because you'll see under testing technique, there's 3 bullets. It shows you the different kind of injections. They don't even have anything to spot. Injection of long the procedure notes specifically state whether or not a approach or into the foramen. You have to know, these codes all are based upon the approach, like anterior posterior with the lumbar, musculoskeletal ones. Lumbar inner body. Then, based upon the approach, the injections are by level, whether or not it's the cervical, thoracic, lumbar, sacral. And then, the levels, whether it's 1 level, 2 levels of each of those. That's a lot of confusion gets, comes into play when people think that they're talking about each additional level of the actual body area, cervical, thoracic. You've got different codes for that. And then those specific to those areas is how many units you're going to have, unless it tells you otherwise. The foramen is the bony opening between the vertebrae through which the lumbar nerve root is. So they go through the bone, that area, that space, to get to the nerve. That's transformial or transformal, however. You'll see foramen a lot of times. Paraspinal nerve injections, sympathetic nerve injections. You're going to see, let me get back, what page did I tell you on 210? You'll see that those bullets in the study guide, you've got your transformial epidural injections, your anesthetic injection for anesthetic agent, or autonomic, is that right? Vertebral, paravertebral facet joint injections, imaging guidance, and it tells you that and all that. But you wouldn't code a transformial or a foramen injection C5 with 64520. That's why it's important to know where you're going. Because if you look up the nerves, you're going to see lumbar nerve, where they've got actual procedures for blocks performed on the facet joints or that space to get to the nerve. You've got a bunch of triangles in this section. The whole nervous system section had a lot of, the injection codes did, had a lot of turning around, a lot of revisions to their code descriptors. You'll see that with these codes, they will tell you if they include the imaging or CT. The reason why they do that now is because they used to not, and you would have to. Well, they are including all of that radiology in these procedure codes now, so be aware of that because it skips from section to section. Another thing to keep in mind with these injection codes is something you don't really think about a lot, is whether or not it's bilateral. You can have injections done on the right side of the vertebra. You see 50? The indicator of 50 tells you that they're applicable. You can have right and left side bilateral C5 injections. If you don't see the 50 modifier 50, and it doesn't matter if it's bilateral or not. With the 50 indicator, they're telling you that you can apply bilaterally. If they don't apply bilaterally, remember right and left. Just they'll have that on test, I'm sure. Your electrical nerve stimulations, transcutaneous electrical nerve stimulations, they're kind of like your pacemakers and defibrillators in a way. If the thinking is the same, you're not always just going to code for the implantation of devices or electrodes. You've got to also think about is it a revision, or is it being replaced or removed, or is it just implementation? And that's what all of these codes will do for you. You get over to neurolysis, a little bit of change there. They resequence things there on page 243. And then these codes are basically at that point you've got your decompression for all of them, surgical for all of them, excisional for all of them, repair, suture, and grafts of all of them. The format just kind of changed. It went by area to actual procedure and then listed each of the specific nerves under it. When you go to the study guide, you go to those injections a little bit more. Usually 217. Let's do some of these scenarios since we looked at all sections. Alright, start at page 152. Let's do 9 and 10. Alright, so when you're reading this, you got your pre and post-op diagnoses are different. They went in thinking they had 6 sinus syndrome with bradycardia, tachycardia, and well, They went ahead and did the pacemaker insertion because of the sinus. So that's still your diagnosis right there. Alright, they've done, a permanent DDD or pacemaker insertion. So that's what we need to think about. DDD is dual, what does it stand for? Dual, and you'll see there's different, I think it's like D. Oh, no, I think the book actually can code them out based upon that type, whether it's a DDR or a DDD. Just to show you, it doesn't make a difference with you going in. Upgrade, single chamber. That's what it is. It's not, the only difference about the manipulators is whether or not it's going to be no, this hits me. Cardio. Pacemakers, you'll need to know if it's a temporary or permanent. It's a pacemaker, single or dual. Defibrillators. Let's just go with that right now. Alright, so sorry. Permanent pacemaker insertion. You've got your informed consent, subclavian artery was perpetrated in the usual sterile fashion. Following local administration of 1% Falcon anesthesia, the left subclavian vein was entered with an 18-gauge thin wall needle shaped wire placed. Transverse incision was created and dissected at the pectoral fascia. A subacute pocket was created and one guide sponge was placed into the pocket. A 7 French sheet introducer was placed, leaving a J-wire in place. Medtronic 5076. And there's the serial number. There's your device. You don't really need to know all that, but you have to code for your device too, if it's out of pocket. Bipolar lead was placed in right ventricle apex. I always like to find out where my leads are placed, and I underline them. The lead screwed into position. The second 7 French introducer was placed. A Medtronic 5076 atrial lead is positioned in the right atrial appendage using fluoroscopic guidance. Measurements were taken and lead screwed into position. Both leads were then suture ligated in position. The gauze sponge was extracted from the pocket. The pocket was irrigated in acid tracing solution. The leads were connected to a Medtronic adaptive device. It was placed in the pocket. Subacute tissue was closed with one row of running 3-0 suture. Subacute tissue was closed with one row of running 4-0. The sterile dressing was applied. Patient tolerated well. Dermabond applied. At the end of the procedure, patient was returned to the room in good condition. I want you to stop there. The rest of it we haven't gone over. I'll explain it after you code the actual procedure, but don't worry about the programming. So we haven't gone. you up for your pacemaker insertion?
33208.
Now, you know, when we were talking about all of those procedures, you know, and you looked for it, you saw that you had your revision codes and all that good stuff. And it was very clear right there that it included the insertion of the device and the electrodes. Now, the device code would be found in your exhibit book. Now, the only thing we didn't code was the programming medicines. They asked you here for your CPT and ICD-9 codes for this procedure. Your initial measures include an R wave of 10.9 MV with thresholds of 0.9 volts, resistance of 8 to 10, whatever. All of that right there, what happens is they will, when they put a pacemaker in, they have to program it. Same with the defibrillator. They have to program it at your personal settings based upon what feedback they've gotten, and they fix it so that the heart's beat exactly the way it needs. So when they push you up, you're good to go. The only thing you have to worry about after that, people go for pacemaker checks or defibrillator checks because the battery can go bad, or if they got batteries in the generator or something, and it can all go bad, or the equipment can actually be at end of life and be time for replacement, or they just maybe experience problems. But it's just like having your labs done if you're diabetic. It's the usual plan of care for pacemaker recipients or defibrillator recipients. Your programming codes are back in the back of the book, your medicine section, and you'll see that when we get back there, that they are based upon programming versus reprogramming or just checking it. It's like 3 different codes, and then of course about whether or not it's pacemaker, defibrillator, 1 or 2 ventricles. Now, if you look at 33208, it usually tells you that the programming, they got an intra or the DO. Have you anyone looked at these codes back here and know which one it is? 999. They had an intraoperative programming code at one time, and I don't know if they changed it. 936. Nine 3279 is what it starts on page 38. You see that there's like 4 pages or 2 pages full of them, and they're specifically for programming and reprogramming of those devices, single or multiple leads. That's where you're going to find it. The instructional note underneath that main category for monitoring of cardiovascular devices, it tells you that what it includes and what it excludes in It's gonna say pacemaker, time period established by the initiation of remote monitoring of the 91st day of ICD or pacemaker monitoring of the 31st day of LR monitoring and extends to the second succeeding 30 or 90 day. Let's see if they carry procedure, that's before. One evaluation and programming, if performed once before and once after report is shooting. Before or after surgery. I'm looking for somewhere in here that tells you that the initial programming is included in the insertion. Okay. Three codes for this one. It doesn't say anything about it.
Is that where it says do not report programming and in-person interrogation on the same day by the same physician? That would be.
No, just saying in general, too. If you look at 93286, it shows you there that this is for the pre, before, or after a surgery, procedure, or test with physician analysis review and report. Before or after the surgery. They didn't code the programming in this book, is why I'm questioning it, because it doesn't tell you not to, and we, at one time, I thought, were coding the initial programming, and the reason why we were coding, if you break it down, you know, a lot of these codes you can understand why things are included or not, and the reason why this one was coded separately was because a lot of the people who do the programming, the physicians of course can, but there's, the equipment used is a lot of contract, and it's not always part of the surgical unit. A provider can actually carry that stuff around with them. They're compact type of machines.
Would that be in the notes possibly, if it were like?
No, they don't, they won't say my equipment was used or whatever. It's time periods established by the initiation of remote monitoring or the 91st day of monitoring. And it stands for the succeeding 30 to 90. Let's say something in here about pacemakers. A physician may not report an in-person or remote nearby. Can be both places at one time. Codes are reported per procedure, no more than once in 90 days, and cannot be reported if the monitoring period is less than 30. That's what it's trying to do. Why didn't you say it like that? Physician may
Says on there, do not report with codes for device evaluation.
not to what?
For device evaluation, not to report with those codes under the includes and excludes.
But
Under what? 3206. But it doesn't say includes. Report with those codes.
are you talking about the 93286?
What about
That's included.
3206? Like where the insertion.
Back on page 110.
And 33208 or what?
Right,
It's right above 33206, it's kind of under the section.
Excludes upgrade if you're there, threshold testing at the same time as insertion or replacement 93640 or 41, which is
no, go down 2 more sentences, Jenny.
do not report with codes for device eval 93279. 93299, okay. So, I guess they're including it with it. So pacemakers you need to next to skin back in. This goes in.
It even says that on the, like in replacement, revision, and repair codes. When would you use them?
Use what?
The programming code?
When they come in for a programming or a reprogramming, and it's scheduled, and that's why they got that time on there, because Medicare and everybody else won't pay it for so many visits, and they've got that, thinking that's the right thing to care for someone with that. But I guess at this point, with that perioperative and preoperative checking would be when it's not in conjunction with the actual insertion of that device. Like if you're having a pre-op for a peripheral vascular surgery or something like that, where they need to check it before, that's when you would use that. And they're including the initial with that is what I'm reading into it. If I find out different, I'll let you know. So anyway, you got that one. Let's go to number 10. What page, John?
153.
Angina. You've got a cabbage bypass times 2 with left internal mammary artery bypass to the left anterior descending saphenous vein graft to the posterior descending branch of the right coronary artery with harvesting of the saphenous vein. All of that right there is real important, but again, it's like we're talking about with those skin scenarios, you just have to read to make sure it's all being done, and this stuff is where I go, I have to think about it. Mr. Williams was taken to the OR after general endotracheal anesthesia. His entire chest and abdomen were prepped and draped and exposed in a sterile fashion. A mid-thigh sternotomy was performed. The left IM is called internal mammary through the IMA. It was taken down from its retrosternal location, proved to be suitable conduit with the bypass. The saphenous vein was harvested. Once both conduits were felt to be suitable, the pericardium was opened and sized and sutured to the skin edges. The patient was heparinized and appropriate cannulas were placed. The patient was then placed on cardiopulmonary bypass at approximately 5.0 liters per minute. The heart was then mechanically arrested with a combination of antegrade and retrograde cold cardioplegia and topical saline. With cardiac arrest now stable, the mid portion of the left anterior descending was identified and dissected free, and the epicardial fat, the posterior descending branch of the right coronary artery, was also dissected free. Longitudinal areotomy was made in the posterior descending, arteriotomy was made in the posterior descending, and a segment of saphenous vein was sutured without difficulty. In like fashion, the left IMA was sutured to the left anterior descending at its mid position. The single proximal end of the right coronary graft was placed around the ascending aorta. Once completed, the aortic cross-clamp was removed, air evacuated from the graft, patient regained sinus rhythm immediately, and appropriate ejection. A single set of pacing wires was placed on the inferior surface of the left ventricle wall, 2 chest tubes positioned. Patient subsequently decannulated and hemodynamically remained stable. Eventually, closure was accomplished with heavy stainless steel thermal wires in a figure of 8 fashion. All wounds were covered with the dressing. Transferred to the ICU in satisfactory condition. Here's how I tolerated the procedure without event. All of the things that I underlined was and you need to know what branch and what artery was messed with, how many grafts were done. And right here, the posterior descending branch is what I've got. Well, I'll tell you how I got underlined. I got the LAD, left anterior descending, the posterior descending branch, the RC, right coronary artery, arteriotomy, which isn't going to make a break because they've got to do that. Posterior descending in a segment of saphenous vein sutured. Left INA, again, sutured to the left anterior descending. So right there you've got your posterior descending branch to your right coronary, and then your left ascending with your internal membrane. So you've got your chin. As it says. So you could code this procedure based upon the procedure right here instead of worrying about all that. not gonna kill me on this one.
Wait, next one,
No, this one.
okay.
So it's,
Yeah, codes.
okay. When you're looking at your bypass codes, the first thing is, we talked about it last class, but we didn't really break it down, but there's two different types of bypass. You go to bypass graft in the index, coronary artery, it takes you to arterial and venous graft. And then you've got two different code sets when you go to those. And depending on the graft is which set you're gonna go to. We have coronary artery bypass times 2, one being a left internal mammary artery bypass to the left anterior descending, and then the other being the saphenous vein graft to the posterior descending branch of the right coronary artery. So, what kind of grafts did we have? The IMA, the internal mammary artery, arterial, and then saphenous vein venous. We
Two
have
venous grafts.
we have one up. The vein and arteries are what they're using to complete the bypass to those locations of the heart. And that's why it's important to know the anatomy to understand what's going on. You just like whatever. When you get to, when you pull that up, like bypass, coronary, and then you're asked arterial versus venous, what made you choose one or the other?
I didn't either.
I'm still checking it out.
Golly. All right.
Not in the right neighborhood on
It would have been 33533 and 33517. But
Well,
here's
we
how you
also
got.
had another code, didn't we?
Mm-mm.
No, there wasn't one. The reason I asked that is because, like, the 33517, under it, it says code first, 33533 through 33536. Did we code one of those first?
33517.
It's 33533 through.
Well, the reason why is because 33517 is an add-on code. You have to add it to
to something.
So that's not called code also.
Right.
And 33533, right?
I use 33534.
Well, no, yeah, but look under 33517, it shows you, it still does that. That's gotta be a typo or something.
It says it under both of them.
Code first, 33533. Single, 2, 3, 4. No, single, 2, 3, 4.
Okay, well, that's right, that's the two, because it says the, yeah, you code the 33533 first, and then the 33517.
Yeah.
Yeah, yeah.
Code also, 33517. That's Venus and arterial, that's one. Okay. The interior, like, you go to the part again. If you go to your cottage guidelines on page 140, it's easier said than done, which y'all can do. Oh, it's almost not out already. But y'all can see it's easier said than done. The guidelines seem real simple until you start applying them. But it shows you, if only venous grafting is performed, that set of codes. Arterial grafting is right there. If both are performed, here. Now, you would have gotten there had you known where to go. I think everyone saw arterial and venous, and it was kind of like, okay, well, which one is it? Am I not wrong? Yeah. But it's going to be either a vein or artery. And you just got to know what was the thing. Think about it when you're reading because I know it's a lot of terms in anatomy that you may not be familiar with. But even that, if you read it, try to find it. With left internal mammary artery bypass. It tells you right there. It's an artery bypass. To here. And then a venous vein graft. It's, when you see graft, I think bypass. To there. Help? No? See it now? You wanna look at another thing? Y'all look like y'all are just mad at me. Or y'all don't care one. I can deal with the heart, but all this other stuff I can't. And the procedure notes don't get any shorter at all. They get pages long, especially when they're talking about bypass grafts. And pacemakers are pretty straightforward. A lot of those actually use templates where they go in and they just put, or whoever's doing their transcription, it's already set and they put the patient's name and indication and the settings. They're that straightforward, and as long as you know what you're looking for, you'll go straight to it. But man, this stuff, it kills me. I mean, look at number 7 on page 151. Using xylocaine, anesthesia, aseptic technique, and ultrasound guidance for vascular access. 21 gauge needle was used to aspirate the right cephalic vein of a 72-year-old patient. Blood was obtained .018-inch platinum tip guide wire was advanced with central venous circulation. A 6-French dual lumen PIC was introduced. What is that? Percutaneous intro. Hold on, I'll tell you. PIC. Percutaneous. Supposed to know these things. Come on, Christy, you're supposed to know this. Pick one.
What's a low numbers pick? I can't deal with them, so I don't miss. I don't care.
I'll do that one. A dual lumen pick was introduced through a 6-French peel-away sheath to the superior vena cava and right atrium junction, and after removal of the sheath, catheter was attached to the skin with a stat block device and flushed with 500 units heparin in each lumen. A sterile dressing was applied and the patient was discharged in improved condition. What is the CPT code for this account? Can anyone tell me what they did?
Inserted a pick one.
What's a pick one? A peripherally inserted central catheter. So, they inserted a central catheter. 36 past the time? Without its philosophy. Because, well, number one, it doesn't have your little radioactive thing right there. You may not have that in your A&E book, but if it doesn't have your radioactive thing crosswalk on it, it means that it's included or what have you. But if you go all the way to the very top, it tells you it excludes and the radiology portion is excluded. And we don't code separately. Let's see what's it saying. The last note of the guidelines for the central venous access procedure indicates that those codes are to be used for imaging. Documentation indicates the procedure was performed with ultrasound. 76937. According to the description of 76937, there must be documentation of selected vessel patency. Oh, they had a totally different reason. So you can code it. Wait. That indicates that codes 76937 or 77001 are to be used for the imaging. But they didn't put it because, according to the description of 76937, ultrasound guidance for vascular access requiring ultrasound eval of potential access sites, documentation of selected vessel patency, concurrent real-time ultrasound visualization of vascular needle entry with permanent recording and reporting. Using that documentation. The documentation to support 76937 is not evident, therefore it is not reported. Okay, that's good to know. That, people, what the term for it is that? That's gonna be, I've been telling y'all, only if they had a little radioactive slime bomb where you to code it separately. Where's the, okay, 365, central convenience, instruction, access. Hey, I'm having class, I'll call you in 2 weeks. And now I'm not ignoring you. I'll call you back in 5 minutes. Why? What's wrong? About what? Are you okay? Okay. Something I need to hear about? Who's the restaurant? I've been avoiding him all day, and if you look, I'm serious. That he's just that he's talking about something I need to know. Alright, so I'm thinking, I've never thought about this. I'm gonna test out my logic. So I say I've been going through this book determine whether or not it needs a radiology portion by the indicator. But they've got the excludes note there, and then right under it, they've got the radiology symbol with the codes that are applicable, I'm assuming, to this code series. And I'm looking at it like this, they're saying that that is not included and you would code it out separately. What I don't understand is why didn't they use the same format for the book? Because there's several other sections and areas of this book where all of that section is applicable to the addition of radiology codes. And they put them under the codes rather than above them. So I guess keep that in mind to go and look up there to see if you'll find them there instead of right next to them and under them like we have them. I've never
Like
seen
on these right here, 36481 to 36510, it's under them. Right next to this one.
36481.
To
Well, on
36510.
those, yeah, but on those, not all of them are applicable, and not not all three of them applicable, but they're different. But like, let me show you. Your injection codes, your nervous system injection codes that we were talking about, there's a series of those that are applicable to radiology, and they're all the same radiology code for each one in the section, and they've got them listed out. Jeannie, what we're saying is that we did number 7 or something in the study guide, and we were looking at radiology components of it, and you'll see what we're talking about when we get there. You're going to be looking for the little radiology indicator that we've been talking about this whole time. That's been evident at the bottom of every code. But if you look at the section starting on page 136 in code 36555, you'll see right where that chapter starts, your includes notes, or section starts. Includes, excludes, they're right under this radioactive sign with those codes, and I've never seen them there before, or I've never paid attention to it before, I've never seen it, because they're usually,
Included in the package.
well, if they're not though, they're right, they would normally, look at, number, 36481. 36481. You see it's got the indicator with the codes under it, rather than anywhere else, and that's how it's been through this book, as far as I've ever been concerned. I've never noticed it there before, and when I read it there, it almost is like it excludes it not to code it, because if you would code it, again, it would look like that. So be just conscientious of that. Destruction codes, where is that? 6 the plastic transforming. Those all include include So this is not the two, these are different. That's why. They're gonna be at the top of each section if they all apply to the same set of radiology codes. Like all of these back here, I thought they were the same, but they're not. There might be one code out of each section that has two different radiology codes, whereas these all are applicable to those two. That's what I'm saying. Alright. There's more going to be had with cardio in the back. So let's move to page 185 for the urinary system. And do number 7.
It's okay. I miss you. Oh, that's great.
She cries at 40 years, screaming bloody murder like I was trying to kill her.
You wait till your mama sees you. Hers gonna know that Grace picture.
Wonder if
That
he
is
knows her at.
beautiful.
Where's she at?
Come here. Come here.
I'll take a picture of that.
Come here. Oh, he's okay, Leo. He's okay. You don't forgot about me. I'm your baby.
She kept one mine taken care of.
Are you okay? Did I make you cry all the time? Why you do that? Should have pulled over.
Mama told me not to pull over. She look at her.
I told you not to what?
Pull over. Or speed up or slow down.
Her's been crying so hard she's done got upset.
Let me dry my hands. Well, you did the right thing by not.
I was kidding.
It wasn't that bad until we got here and we stopped.
Yeah.
I did.
And then I started making her a bottle, and that just made it worse. So,
When you got here, you did?
yeah.
It's okay, you did good.
cystoscopy for a mass in the left bladder wall. Not sure if it's malignant or doing biopsy. It's cold, but oh, bless you. Oh. So if you go to cysto, well, if you went to cystoscopy and then with biopsy, bladder, cystoscopy. So then you go over here, cystoscopy, and then bladder, biopsy. Cystoscopy, biopsy, bladder. You can't get it that way, you're gonna have to go to biopsy. Oh. They just said they were biopsy, so there was no fulguration or radioactive substance. It wasn't an open, it was cystourethropy. So look at codes 52224 and 52250.
It does have that full duration or whatever. Is that what you're saying?
It does?
Yeah. The ones, the stuff that were not biopsied are full durated or whatever.
Oh, it sure is. I see it right here. So with fulguration, 52224. With fulguration including cryo-M or laser or treatment of minor less than 0.5 lesion without biopsy. And this lesion is 1.5. So this would be considered a small bladder lesion, 52234. Correct? Y'all good with that? Just checking. Check it to this side. Yep, that's it. See, when you start doing ones like this, it makes you feel like, okay, like it was last time where we were looking them up and it's like, okay, okay. And then cardio's like,
Yeah.
A neonatal male, number 8. A neonatal male has an elective circumcision before being discharged home. The physician uses a ring block for the local anesthesia and a foreskin is placed over the glands. A clamp is selected for the size of the glands and a circular ring is placed over the foreskin to compress and devascularize. The foreskin is excised with the scalpel, the ring device is removed and distressed. Oh, her not sneaking in the door. She's gotten so big, it's only been two.
Yes, I know, you just understand it looks like so I don't,
She has.
I don't see it like it.
Right, and she's all over the place. And I mean, she was just showing us emotion. That was raw emotion. Child was distressed. So I'm with you, you don't even I almost died from the debate.
And we'll come back and visit now, because that's,
Bye-bye.
I'm just glad my books are
Bye-bye.
coming tomorrow. Are you gonna be here tomorrow? Cause I'll come out with that too.
Yeah, I'll be here. Love you. If I'm not, just call.
I'll just come back, but just gonna up wrap it up. We're gonna have a girl, that's why I said that was Randy. She asked her if she can pick the, you know, have a picture, so I guess we're gonna go see you after that.
I do know that last time we were up there, I don't think Wendy's the one who's doing it.
At McGee? This is McGee.
Huh?
No, we do see McGee. They don't have a 13-18-year-old now.
They have one small, or they did, they had some big old ones up there one night. Chris, did you see them in the hot pink?
Whatever, I thought almost all the softball was
Yeah.
Always thought it
All the girls.
But all I know is there was some girls
I
in
don't
the
know.
field the other night.
they might have small things, they never.
Go anywhere. Or do anything.
Well, the girls they were playing were much bigger than they were. And they were like,
No, they've never played for the league. Well, the brothers don't come in all my kids are older anyway, so we get to see it.
Make you
Well,
feel
so-
like you and they work you, they make you do.
I talked to the coach tonight, so we just, I thought I was gonna have someone.
yeah, right. Yeah, right. You should have known better.
I didn't have.
Okay,
Y'all have a good night.
You should. Circumcision with clamp or other device. And how old was it?
Yeah, I know.
Yeah, so. Apple 150 or 4,600. Which one y'all get?
Top 4 and top
541. 5. Is it? Robin, you can see